So let's start with the second class of bronchodilators, that is methylxanthine. We will learn the drug's mechanism of action. We will learn in detail about the pharmacological actions, and the main drug we will study out throughout the methylxanthine is a theophylline. So let's start with the theophylline. So theophylline and its compounds have been extensively used in asthma but are not considered first line drugs nowadays, and they are oftenly used in COPD. Theophylline is one of the three naturally occurring methylated xanthine alkaloids. They are as follows, like first caffeine, then second theophylline, and third one is a theobromine. The chemical relation between these three we will learn in the medicinal chemistry, and let's see about in general introduction about these three alkaloids, that is a caffeine, theophylline, and theobromine. So they are consumed as beverages. This is day to day used beverages we are using, and we'll see just in short the sources and the average alkaloid contents of the beverages. Like say for example tea leaves, the source of tea leaves we know Thea sinensis, and alkaloid content is caffeine and theophylline in the tea leaves. We all know this very well. And in an average cup of tea we will find 50 mg of caffeine and 1 mg of theophylline. Then in coffee arabica, that is our coffee seeds, it contains caffeine. Near about 75 mg of caffeine we will find in the average cup of coffee. Then cocoa or chocolate, that is a Theobroma cacao. It contains theobromine almost 200 mg, and caffeine 4 mg in the cup of cocoa. And this is all about the alkaloid contents in the tea leaves, coffee, and chocolates. So all three alkaloids have qualitatively similar actions, but there are marked quantitative and pharmacokinetic differences. So this is about the theophylline. Now let's learn about the mechanism of action. Here mechanism of action, there are three distinct mechanism of actions of methylxanthine compounds, in which the release of calcium ions from sarcoplasmic reticulum, then inhibition of PD, that is phosphodiesterase, so produces intracellular degradation of ATP and increased production of CAMP. So following functions occur in this: bronchodilation, cardiac stimulation, vasodilation, then blockade of adenosine receptors, in which increased intracellular level of adenosine in CVS and CNS, and smooth muscle cells causing these effects, like bronchodilation, then cerebral artery dilation, cardiac pacemaker inhibition, and gastric secretion inhibition. So let's learn in detail about this pharmacological action basically, that is a CNS, then CVS, then smooth muscles, kidneys, then skeletal muscles, stomach, mast cells, and inflammatory cells, and metabolism. So let's have in a table format so that you can learn it quickly and remember for a long time. So we will see these two, CNS and CVS. Now you can read out this effects on CNS and effects on CVS. Let's have some discussion on CNS. Like caffeine and theophylline are CNS stimulants, we know it's already. Primarily it affects the higher centers. Caffeine dose is a 150 to 250 mg, produces sense of well-being, then alertness, beats, boredom, then Alice fatigue, then thinking becomes clearer even when dullness has tended to prevail after a sustained intellectual effort. So this is about the caffeine. In a 150 to 250 mg, it produces sense of well-being. Now it tends to improve performance and increase motor activity even. Caffeine is more active than theophylline in producing these effects. So higher doses cause nervousness, then restlessness, panic, insomnia, and excitement. Still higher doses produce tremors, then delirium, and convulsions. So, theophylline has a greater propensity to produce these adverse effects at higher doses, and it's definitely more toxic than caffeine. They also stimulate medullary vagal, respiratory, and vasomotor centers. Also, omitting at high doses is due to both gastric irritation and some stomachache problems. So, this is about the effects on CNS due to caffeine and theophylline. Now, let's talk about some serious effects, cardiovascular effects. So, here methylxanthines directly stimulate the heart and increase force of myocardial contractions. Now, we learn this myocardial contraction in the cardiovascular system, but they tend to increase heart rate due to this contraction and by direct action, but decrease it by causing vagal stimulation. So net effect is variable, it's depend on patients to patients. Then tachycardia is more common with theophylline, but caffeine generally decreases heart rate. Remember, caffeine generally decreases heart rate. Now, cardiac output and cardiac work are increased, and high doses cardiac arrhythmias may be produced. Basically, here methylxanthines, especially theophylline, dilate systemic blood vessels, including coronaries by direct action. Then peripheral resistance is reduced in this. However, cranial vessels are constricted, especially by caffeine. This is one of the basis of its use in migraine. Now, what is effect on BP? So, effect on BP is variable and unpredictable here. In this vasomotor center, and direct cardiac stimulation tends to raise the BP, and vagal stimulation and direct vasodilation tends to lower BP. So, usually a rise in systolic and fall in diastolic BP is observed during this drug therapy. Now, these are the effects on CNS and effects on CVS. So, let's see the effects on smooth muscles and kidney. So, basically, smooth muscles, all smooth muscles are relaxed. Most prominent effect is exerted on bronchi, especially in asthmatics. Theophylline is more potent than caffeine here. Slow and sustained dose related bronchodilation is produced, but the effect is much less marked compared to inhaled beta 2 agonist. Then vital capacity is increased, biliary spasm is relieved, but effect on intestine and urinary tract is negligible. Now in kidney, methylxanthines are mild diuretics, act by inhibiting tubular reabsorption of sodium ions and water. In addition, vascular effects may result in increased renal blood flow and glomerular filtration rate also. Theophylline is more potent, but action is brief here in the kidneys. Now pharmacological actions on the skeletal muscles and stomach. So let's see about the skeletal muscles. Here, caffeine enhances contractile power of skeletal muscles. At high concentrations, it increases release of calcium ions from sarcoplasmic reticulum by direct action. And at low doses, its response to nerve stimulation is augmented. While at toxic doses, contracture is produced. In addition to this, caffeine facilitates neuromuscular transmission by increasing acetylcholine release. Its central action relieves fatigue and increases muscular work. It also enhanced diaphragmatic contractibility noted with theophylline in the therapeutic concentration range, probably contributes to its beneficial effect in dyspnea. So this is about the skeletal muscle effect. Then in the stomach, methylxanthines enhanced secretion of acid and pepsin which are present in the stomach. And even on parenteral injection, these are enhances the secretion of acid and pepsin in the stomach. They are also gastric irritants and theophylline more than caffeine. Theophylline gastric irritation is more than caffeine. So this is about the stomach. Now, mast cells and inflammatory cells and the metabolism. So, in the mast cells, theophylline decreases release of histamine and other mediators from mast cells and activated inflammatory cells. This may contribute to its therapeutic effect in bronchial asthma. And in the metabolism, here the part of caffeine, role of caffeine and to smaller extent theophylline increases BMR. uh, Plasma free fatty acid levels are raised here in the metabolism. Then release of endogenous catecholamines appears to be partly responsible for these effects. So this is all about the pharmacological actions of the methylxanthines. Here we have seen the theophylline, caffeine, and even methylxanthines. What are the roles in the different parts of the body? Now let's see the pharmacokinetics uses and adverse effects with the interactions and dosage. So pharmacokinetics, basically this drug is well absorbed orally, theophylline. Then rectal absorption from the suppositories is erratic. It is distributed in all tissues, also crosses placenta, and it's secreted in the milk. Then 50% plasma protein bound and extensively metabolized in liver by demethylation and oxidation. This demethylation and oxidation reactions we will learn in the medicinal chemistry. Then only 10% is excreted unchanged in the urine. Its elimination rate varies considerably with age. And at therapeutic concentrations, the T half in adults is 7 to 12 hours almost. In children, elimination is much faster than adults, that is in within 3 to 5 hours, and elderly it's more slowly. In premature infants, the T half is prolonged, it's almost 24 to 36 hours, and there are marked inter-individual variations in plasma concentrations with the same dose of the drug. Then theophylline metabolizing enzymes are saturable, and T half is prolonged with a higher doses. So almost up to as much as 60 hours. And as a kinetic changes from first to zero order, here plasma concentration and therefore increased disproportionately. Now let's see about the uses of theophylline in the methylxanthine. So basically bronchial asthma, it is used in bronchial asthma, COPD, and apnea in premature infant. In bronchial asthma and COPD, theophylline benefits by causing bronchodilation as well as presumably by decreasing release of inflammatory mediators, which improved mucociliary clearance, stimulation of respiratory drive, and by augmenting diaphragmatic contractibility. So this is the action by which it relieves the bronchial asthma and COPD symptoms. However, because of narrow margin of safety and limited efficacy, its use has declined nowadays, and oral theophylline can be used in mild to moderately severe asthma as a third line or alternative adjunct drug, especially in patients with a nocturnal asthma. It is more useful in COPD basically than bronchial asthma. Also, use of intravenous theophylline in status asthmaticus is outmoded nowadays. Then, in apnea in premature infant, this theophylline reduces the frequency and duration of episodes of apnea that occur in some pattern infarcts in first few weeks of life. And closely monitored oral or intravenous treatment is employed for 1 to 3 weeks. Caffeine is equally effective in these situations. Then come to the adverse effect part. Theophylline has a narrow margin of safety. Its dose dependent toxicity starts from the upper part of therapeutic concentration range, and adverse effects are primarily referable to the gastrointestinal tract, central nervous system, and cardiovascular systems. Children are more liable to develop central nervous system toxicity in this case. Then the irritant property of theophylline is reflected in gastric pain with a oral dose of theophylline. Then rectal inflammation with a suppositories dosage form, and the pain at the site of intramuscular injection. Then rapid intravenous injection causes precordial pain and even sudden death due to marked fall in blood pressure, ventricular arrhythmias, or asystole. So these are the adverse effects. Now let's see about the interactions. Here interaction divided into two types, that is the agents which induce its metabolism decreases its plasma level, and the agents which inhibits its metabolism increases its plasma level. So here the agents, the considering factors I have enlisted in the table only. So let's discuss about the interactions. In this, basically agents which induce theophylline metabolism decrease its plasma level, and dose has to be increased by the factor given in parenthesis, like smoking, then phenytoin, then rifampicin, phenobarbital, then charcoal broiled meat meal. And the drugs which inhibit theophylline metabolism and increases its plasma level are erythromycin, ciprofloxacin, cimetidine, oral contraceptives, allopurinol. The dose should be reduced to 2/3. Then theophylline enhances the effects of furosemide, then sympathomimetics, digitalis, oral anticoagulants, and hypoglycemics. And theophylline decreases the effect of phenytoin and lithium. Then aminophylline injection should not be mixed in the same infusion bottle, infusion bottle or syringe with the ascorbic acid. Then chlorozapamine, then promethazine, then morphine, phenytoin, penicillin G, tetracyclines, erythromycins, then insulins, etc. Now let's see the dosage. Basically, the preparation and dose of theophylline is a poorly water soluble. It cannot be injected. 100 to 300 mg TDS means 15 mg per kg per day is the dose. Then for aminophylline, 85% of theophylline water soluble can be injected intravenously, but not intramuscularly or subcutaneous. It's highly irritating. The dose is 250 to 500 mg oral or slow IV injection. In children, it is 7.5 mg per kg. Then hydroxyethyl theophylline, in this water soluble, this hydroxyethyl theophylline and hydroxy group is contained and can be injected intravenously and intramuscularly, but not subcutaneous. It's less irritating, and 250 mg oral or intramuscular or intravenous we can give. Then choline theophyllinate is 250 to 500 mg oral dose is available. Then theophylline ethanolate of piperazine, the dose is same, 250 to 500 mg oral or intravenous. So the double salts or derivatives of theophylline are claimed to be less gastric irritant and better absorbed. That's why this theophylline molecule always comes in salts form or derivatives form. However, anhydrous theophylline is completely absorbed and gastric irritancy is same in terms of theophylline content. So this is all about the theophylline, that is a methylxanthines, which comes under the class bronchodilators.